Thank you, Dr. Rajesh. Thank you for making me part of this in-depth discussion of all aspects of keratoconus and such a relevant topic for all our clinical practices. Whether be it the cornea specialist or the general ophthalmologist, we all come across these cases every now and then. A very good morning to all of you. Thank you for being here. When should keratoplasty be done? We come to that aspect now. Well, progression, thinning, and bulging as it goes on, despite all the other modalities that have been used, will give us a significant distortion in the cornea and a blur which cannot be finally fully corrected with all the other means. So in these cases, advanced cases, the loss of the vision can be addressed with surgery. Majority of these cases which go into surgery, we will want to have a precise outline as to when to go for it, like especially when you are out of your training and all, there's always this dilemma. What would be the right time, or am I taking the right decision for my patient by subjecting them to surgery now? So there are no indices, metrics, or any of the features on say ASOCT or topography, because there's a poor effects as in the patient's comfort and the patient's vision and day-to-day functional requirements. Yet, when do we consider surgery? It's when there is a very high regular astigmatism. There could be scarring, which could be primarily because of the keratoconus, or it could be secondary to hydrops. This leads to the functional loss of vision, which cannot be corrected adequately, or the other means like contact lens are now not tolerable. Visual excess is not spared. There is obscuration of the visual excess, or other means of halting the disease are now exhausted. You tried the other things, but still the visual requirement of the patient is not addressed. There has been a past episode of an unpleasant episode with the contact lens, or if we still want to go by the grading, if the stage 4 by AK classification, where the refraction is impossible, corneal diameter is very high, pachymetry is very low, and there are central scars. So for those of us who would like to have a definite flow chart of design as to this is to be done when this, then there is this criteria where you can look for a progressive disease, yes or no, and then the grades 1, 2, 3, 4, and accordingly the final thing on the chart would be the corneal transplantation when there would be a grade 4 or higher up. But then we can have surgery by choice also. If you are a very conservative person, or if the patient is conservative, have read up a lot and does not want to be subjected to the side effects or the adverse situations which come from the other modalities, very few of them would probably want it. Or when the surgeon is very of the query effect of the ultraviolet light or the riboflavin and the combination on the stem cells. And of late, what has been reported has been the gross thinning of the cornea post 6 months to 2 years to 5 years of cross-linking, where you see a very thinned out cornea, a sort of absorption of the stroma post this. So classically, what type of surgery? It is penetrating keratoplasty, which used to give excellent optical results, and this was the best indication for getting the best outcomes in keratoplasty. But of now, DALK is the chosen one because we are going to spare the healthy endothelium of the patient. And for the other obvious advantage where the rejection will be less, it is not an open sky technique, there's a stronger eye, there's little work to do in the anterior chamber, no risk of rejection, there is less requirement of the steroids and the secondary risk of glaucoma. And it can be modified in different way if we have available femtosecond that can also be used. And there are techniques where the bubbles are to be done, and it can be the different types, which is not in the scope of this discussion. But at the same time, despite all this done, and if you're going for surgery, you will want to keep the allergy in check. So many of the patients would have associated vernal keratoconjunctivitis. And if we don't keep this in check, probably only the period while the steroids are on, the patient might remain comfortable. But then the allergy, if it comes back, None of the other modalities are going to give you consistent result for a long time, and that too in after keratoplasty, that graft can also become ectatic if there is constant rubbing in the eye because of itching. So the different modalities which are required are shown in this flow chart and can be used in different combinations, but the mainstay would remain as allergen avoidance, a cold water lavage, cold compression, and mast cell stabilizing agent, which can be given for a long time after the surgery along with the post-surgical treatment. If this is not checked, and if you're looking at the outcomes, these are a few photographs of this farinaceous keratopathy with this ropey discharge, this floor-like dusting on the surface. These are the cases which need to be looked into very carefully, because they would have this upper lids with large cobbles, and these are the patients who are likely to have such reactions, prolonged reactions in the sutures post-keratoplasty for keratoconus. And these need long-term steroids, and then later on, these patients do well on tacrolimus ointment also. So it would be nice to treat this preoperatively. So again, when keratoplasty, when this has been treated and taken care of, otherwise the surface would not be good enough to keep the sutures good. And once the sutures tend to loosen, you need to replace them. And there'll be, as shown here, there would be localized ectasias because of the loosening of the sutures, and this would again give irregular astigmatism. So the idea would be to have a block-to-block connection, but this is not how it is in keratoconus. Our cornea would be thinned out. So we would want to watch out to give this edge-to-edge connection and not a disparity on the surface. And thereby you get a regular surface like that. So to get a clear graft like this, it is important to look into these aspects beforehand. Supposedly, if you had a pre-operative keratoconus patient with scarring, yet a DAL can be attempted, there might be a bit of this residual scarring around it, or if on table during surgery you ended up with a small opening in the descemetes, you can still go ahead with the surgery, because if this is off the excess, you will still get reasonably good visual outcomes. This scars remain at the edge and the visual excess is spared, so you still get reasonably good outcomes. To be a little more careful, we would want to avoid double chambers or a gap here. Here there is a little separation which leads to localized edema, which resolves on its own sometimes if it is small, or with a rebubble. There can be distortions like this in the graft, a torque-like effect which should be taken care of during surgery, so that again you don't get those irregularity. If these are in periphery, they don't really matter, but usually you can steam them out or roll them out in the central part. Of course, we would all be dreading this infections, and due care should be taken for that to get the good surgical outcome. Add-on surgeries would be required, as in when there's loose sutures, replacement of the sutures, or if there's an irregular astigmatism on healing, top-up surgeries for that can be required. Finally, to conclude, there should be no transplant done if myopia and astigmatism is correctable, optical aids are well tolerated and can be made tolerable, cornea is clear in the visual axis, there is no scarring, no edema, progression is under check with the other means which have already been discussed, and there is a monitored compliance for keeping the allergy quiet. So, and if this all is looked into, the vision would be good enough and keratoplasty would not be required. Thank you so much for the patient hearing.
Thank you, Dr. Jagruti. It was a nice insight into when and how to do keratoplasty, what keratoplasty to be done. And just one last thing, if there's any question on this topic, do you have any? Yes, sir, please. Sir, we can't hear you, sir.
Sir,
We can't hear you, sir.
Please use the mic.
See, vernal keratoconjunctivitis is a very common thing. It was initially called as a spring catarrh. But you do have a corneal manifestation of spring catarrh, which is not dependent upon the conjunctivitis, called a dystrophy. So, in this condition, you have a immediate dystrophic manifestations, the delayed dystrophic manifestations. The immediate dystrophic manifestations, you have got a called of a kind of a synovial toxon, which mimics a true arcus sinalis, And the delayed dystrophic manifestations are in the form of keratoconus and keratoglavus. I want to ask Professor Sinha Saab, how many cases of keratoconus, this vernal PKH, you have seen keratoconus? Thank you.
There are many actually cases of VKCs. They do get keratoconus, secondary keratoconus. There are many cases, and the only thing is that's why whenever a child comes with a VKC, we have to aggressively manage these cases, and we have to explain to the parents as well as the child not to rub the eyes, because that has been. And rubbing of eyes not only has a mechanical effect, but it is also an indicator that the child is having significant inflammation in the eye, significant evidence of VKC. So that is why it has to be aggressively treated. Otherwise, a large number of such cases will get keratoconus. So
Just
that
to
is
to add on to this, rather than in context with our topic for the course, how many do get keratoconus? Instead, how many of the keratoconus patients have allergy, and how should that be addressed would be of concern as related to the course topic, I guess.
Yeah, that's true,
Because how many actually are being treated for keratoconus, and out of that, how many are having allergy? And how we take care for that is probably what would matter in relation to this
You see,
course.
the problem is that what I have seen in the past 30, 40 years is Kashmir is very common because of this allergy and the pollen and stuff like that. There's a self-medication of of steroids. They get the steroids a dramatic effect. And I've seen about 4 or 5 cases of conjunctivitis who have got a steroid-induced glaucoma, and they have lost their eyes. They got a glaucoma optic atrophy. They are on anti-glaucoma medication. So it's very important that they should not self-medicate themselves steroids. You have got now the proper modality of the treatment of our conjunctivitis. What I give is that I give, obviously, you have olopeptidine, you have cyclosporine, you have, and I have never in the present status given steroids. Okay, you can give mast cell inhibitors. There is a very good modality of mast cell inhibitors because we know that they will prevent the release of histamine from the mast cells, and it's basically a prophylactic. And the thing is that the mast cell inhibitors are not so much common. It should be used just at the start of the pollen grains. I have never in my practice given, because I have seen 4 or 5 young patients who have lost their eyes, even have undergone a trabeculectomy. The other severe cases of vernal conjunctivitis, they get a vernal plaque or shield ulcer. It's a very miserable condition.
agree with you, sir, because if the patients don't follow up, then and they are using the steroid for a very long period, they may have complications. And use of cyclosporin, as you said, and also tacrolimus is something which is very effective in these cases. So if we have any doubt that the patient may not come for follow-up, in such cases, maybe we can resort to tacrolimus along with cyclosporin and avoid steroid. But yes, there are many cases which do require steroid, and we have to explain to the patient and the parents that regular follow-up is needed. I think a good chair time is what is very essential to manage these cases.
Professor Sinha, in your follow cases, how many cases of vernal plaques you have seen in VKH?
So I'd like to make a comment here. Whatever you are saying is absolutely correct. It is our duty whenever a patient of, because yeah, they are usually children, it's our duty to counsel their parents that there should not be any injudicious use of.
Yes.
I work at PGI, which is a tertiary care center. We have referred from almost 6-7 states: Punjab, Haryana, Himachal, Uttarakhand, Bihar, Uttar Pradesh. And we see a lot of cases of secondary glaucoma as well as secondary cataract. And as you said, most of these cases are because of self-medication. Nobody told them how to use these steroid, and they keep, because they give them relief, so they keep on using these drops and end up. But besides that point, once they use it, then they usually don't end up in a keratoconus because once they are not rubbing the eyes, but we see a lot of VKC patient having keratoconus also. As literature says, almost 40% of people with atopy are associated with keratoconus. No, which is very high figure. And of course, the patient with the vernal corneal ulcer, though they are in periphery and if treated again initially, they don't lead to much sort of many these cases are having keratoconus also, but if they get secondarily infected, we have seen many cases where vernal catarrh gets secondarily infected either with fungus because they are using steroid again and or even bacterial. Then there is a very irregular astigmatism. I have personally done in maybe 10 cases anterior lamellar keratoplasty following infection and these vernal catarrh corneal ulcers because the cornea become thin and irregular, and you have to prevent the vascularization in these cases because if it happens you are not able to do even a lamellar keratoplasty. So we have to be very careful with these children, and we have to consult the parents of these children and use only soft steroid which can be used for 1 year or 2 years altogether without having the side effect like lotiprednol, low strength 0.2, and we have to have a pulse therapy, not to use dexamethasone or prednisolone, which people use right and left. And once they leave, they are from distant places, they keep on self-medicating themselves. So it's our duty to educate the public at large.
Last observation, Amjad Hussain Rahi, who was an oculoimmunopathologist in Morpheus Eye Hospital, has done a lot of work on vernal plaque. And his lot of articles are in the British Journal of Ophthalmology. One should go and listen to his Amjad Hussain Rahi, oculoimmunopathologist, an Indian basically with a British nationality who did MD from Ligad, and then he did MRCP path, oculoimmunopathologist. I have heard his lectures, he's a FRCS examiner, and he has done a lot of work on this vernal plaque. It's better to go through this British Journal of Ophthalmology to listen to read his vernal plaque, what he says. There are 5-6
I
points.
would like to say the literature from India is much more than we have paper from North as well as South India, and we have to treat it early, scrape them, amniotic membrane, and judicious use of steroid. There are so many studies from Maharashtra, from LBPI, even from our center, PGI. So literature, I mean, we have